Bismillahirrahmanirrahim. Hello everyone. This is Hossam Ziada, Assistant Professor of Ophthalmology at Azhar University, Cairo, Egypt, founder of Ziada Eye Academy, and President of the Egypt chapter of the International Society of Manual Small Incision Cataract Surgery. Today I will talk about converting to manual small incision cataract surgery in the Middle East, especially for the phacosurgeons, as a new perspectives for this technique. Before going to my presentation, I will tell you about some notes about the history of this technique during my life practice. 12 years ago, I have learned the small incision cataract surgery, the manual technique of the scleral tunnel, which was done as a sutureless, non-phaco surgery. And at that time, I mastered this technique, and I was a senior of a list of a small incision cataract surgery in one of the specialized eye hospitals here in Egypt. Then I turned to the phaco emulsification, and then I mastered the phaco. And when I have mastered the phaco, I went through the phaco emulsification in the different situations and the different challenging cases and in all types of cataracts, from the soft cataract and up to the cataracta nigra, or the dense brown hard cataract. But finally, after doing all that cases, I found finally that there is no need for more putting myself in this stress and in these challenges, because I have done. There is no need for practicing of these hard times, because actually the outcome of the patient's eye, or I can see it, the outcome of the visual rehabilitation, of the visual improvement after the surgery, is the most important point after surgery, regardless the technique. We have social problems here that most of patients are hearing from each other about the newer techniques, about the sutureless techniques, and they may Google for it. But actually, you are the only responsible one about the choice. You have to tell your patient about the choice with your knowledge and with your experience and with your responsibility at the same time. So I found myself in a bad need to return back to the small incision cataract. This manual technique, which will provide me the safer surgery, and at the same time the elegant one, because there is no stitches and there is no astigmatism. There is no problems with the corneal corrugation, the corneal irregularities with the corneal stitches, and at the same time there is no hurting for the endothelium with the over thermal power of the ultrasonic waves during dealing with the very hard cataracts and the black cataracts, especially with the old patients with vulnerable cornea or the vulnerable capsule, because it's so easier to deliver the nucleus and to deliver it from this tunnel without hurting any of the ocular tissues, provided that mastering of the steps of the manual small incision cataract surgery. So I'm talking today about the responsible one, not only a fan of this technique. I'm the president of the Egypt chapter of the International Society of the Manual Small Incision Cataract Surgery, and I got this honor and this push from Professor Amalio Saho from India, the founder of this society, and with the support of the all expert surgeons in this technique, which who can do it in all situations and using it all, as I will show in my presentation. So this society was established on 2005, and it has had more than 25 national and 12 international chapters. It's interested, or it's conducting studies for the research and development of this technique of the cataract surgery to be accessible, to be affordable, and give patients the best of vision. And if you want to check it on the website of this society, you will find that our chapter is registered. You will click the chapters and then the international chapters to find our country, Egypt, is registered on the website of this society. And here is my professor, Dr. Magdi Khalaf, the honorary president. I am the president-elect, or the active president, and my professor, Dr. Hisham Fauzi, is the chairman of scientific committee, and my dear colleague, Dr. Mahmoud Shafiq, is the general secretary. So I'm not just a fan for this technique, but I have to conduct my love and my calls for this technique here in Egypt by conducting training courses and support for the surgeons. It's just political jokes, but there is no need for it here. So I'm representing them in Egypt and in all Africa as well. And this is the party or the ceremony of launching and signing the contract of having the presidency of the Egypt chapter. It was during the All India Ophthalmological Society conference in New Delhi 2 years ago, with Professor Amalio Saho, who is shaking me now, and on the other side, Dr. Pramani and Dr. Prakshit Guget, are experts of this. So step to step in this technique, in my opinion, and from the life experience, that all cataract surgeons should be fully equipped. Every cataract surgeon should know and should master all techniques of cataract surgery, to start with the extracapsular cataract extraction, then the manual small incision cataract surgery, and the phaco as well. So it's my advice all the time to my residents in my university: you have to master first all steps perfectly of the extracapsular cataract surgery before going to the phaco, because if you are if you jump into the phaco technique, and you will like it, and you will master it, and you will forget the extracapsular cataract surgery, which is very important for you to be safe and to be able to manage any complication you may get during the phaco emulsification, especially in the complicated cases or the difficult cases. Also, the manual small incision cataract surgery could save you and could help you in such situations. So the manual small incision cataract surgery versus phaco could be in cataract nigra in the very old age with hard cataracts, also in patients with vulnerable corneal endothelium and or capsular bag. I will show in this video 2 cases. One done, I was a surgeon. I have done this case with the manual small incision technique, and then the next one with phaco, and almost with the same degree of cataract, the dense, very dense brown or even black cataract. Yeah, I'm cauterized now. The part of sclera where I will put my incision. I used to make my incision to 2.5 millimeter from the limbs. I just I just dumping in my comments about this video because it's very fast. So I'm doing the rexes even without stain. Then I will deliver after opening of the tunnel into the anterior chamber with the keratome. I will deliver this very big nucleus into the anterior chamber. And I will complete this delivery with a viscoelastic to keep protecting the endothelium, as you see now. Then by the sandwich technique, I will deliver, but is so big in relation to the 6.5 millimeter incision. So I completed the visco expression, then the wash, then putting the visco material, and then the IL 6.5 BMMA IL in bag. And finally, there's no problem with the hydration of the wound lips and the side port, the only one side port, and then my lovely air bubble, and closing and covering with a sclera tunnel with just cauterization of the approximated bars of the conjunctiva. The same case with the same degree of density, but with phaco. And I was also the surgeon. After rexes, yeah, with the phaco, sculpting, grooving, and then dividing by the phaco chop, then the regular standard phaco chopping. Then I will furtherly dividing into many fragments. But I was keeping cooling of the endothelium every other step and on emulsification of every other fragment with a viscoelastic to keep it from the thermal effects of the ultrasonic power. Finally, both cases was well ended in peace, but actually this is the picture of the two eyes. 2 days post-operatively on the right side after the manual small incision, and on the left side after phaco. You may notice the difference between the corneas. You may and you may feel the comfort of the patient on the right side and the blepharospasm on the left side, or maybe the photosensitivity on the left side, because the very mild degree of corneal edema, but still having the photosensitivity and cannot open. This patient couldn't open his eye comfortably. The difference between both photos is easier technique on the right side without any stress on your coronaries, without any stress on the capsular bag, on the zonules, and at the same time you are still saving the endothelium. You are not worried about the corneal endothelium. You are not worried about the corneal edema at the first morning after surgery, which may go in some patients, especially if you didn't get the endothelial count before surgery. You may go in corneal decompensation. You're a very skilled surgeon, but actually you may lose the cornea because of a mistake like that. So in my opinion, and in my practice now, I shifted my mind. If I got a case of cataract nigra, or the very hard cataract, or cornea, or a patient with bad cornea or vulnerable endothelium, I will plan from the start to do it with a manual small incision cataract surgery without any fear, without any worry about the outcome post-operatively. So I'm doing that all my days. Also, let me to show this case for you, not to put yourself in this bad situation. If you were if you were me, if you were me, I think you would think in another way. I started this case as a FACO because I put it inside or within a FACO list, and I didn't plan for the small incision cataract surgery. So this male patient is 90 years old, very old man, with a very dense cataract. But actually, when I started the phaco technique, I found that the capsular bag is dancing, is moving with me during the rex's creation. I found the bag is coming with me with some traction on the zonules, which was weaker and elastic than in the younger age. So I decided to stop. After grooving to stop the phaco, and then I turned my mind to complete the division by these two instruments and to deliver one of them in the anterior chamber, to deliver it as a small incision cataract surgery, but through a corneal wound, not sclera wound, because the tension was very soft and I couldn't think in creation of the sclera tunnel. I lost this plan from the start. Then I will increase or widen the corneal wound to deliver this big nucleus but in two halves. Using the irrigating scope, I will deliver the first one. It's more or less an obstructed labor, so it's so hard to deliver. But I was keen not to increase the width of the corneal wound. So I delivered both of them in the piecemeal delivery, instead of increasing the width of the corneal wound to keep it with the least stitches. Then I'm doing it again. Then I finished. This is the last one, but it was horizontal, so I will turn it to be vertical. For easier delivery. Then it's okay, but oh my God. Finally, I delivered all the nucleus particles outside the eye, but I got a vitreous loss. I don't know why and when, but finally I had a vitreous prolapse in the anterior chamber, so I'm doing anterior vitrectomy with this occutome, which will cut and aspirate the vitreous, as well as the cortical and nuclear fragments remaining in the anterior chamber and in the pupillary area. Then, after completion of the proper anterior vitrectomy, I will speed it. I could put the hard IOL on the capsular of the anterior capsular support in the sulcus. Then after turning, I will put my the corneal stitches, just 2 stitches, with the final hydration of the bones, and then the air bubble. And the pupil is rounded, regular. There is no vitreous in the anterior chamber. I was sure about that before ending the case. So after that, let me to conclude about these videos and about this practice and experience, that the manual small incision cataract surgery in the very dense brown and the cataract nigra could be a better solution than phaco. It will save the cornea in cases who are very old or with bad endothelium, keeping the procedure sutureless. And I think you don't need more than this, as well as covered wound to protect against infection, especially in the immunocompromised patients. It's not provided, it's not present with the extracapsular. The wound may be exposed and may be gapped. But in the manual small incision, it's covered with a conjunctiva. Really, and I will talk about my experience with the skilled surgeons. It will take shorter time and cheaper cost, as well as safer trip. In the cataract nigra, when I have done with phaco, I took about 15 minutes, I think. But with a manual small incision, I took about 6 minutes, not more. Other perspectives about the manual small incision cataract surgery, it is with very less astigmatism. I reported a decreased astigmatism down to 0.7 diopter after manual small incision by putting the straight incision 2.5 millimeter from the limbs. The far the incision from the limbus, the less the astigmatism. Could be combined, yes, even in soft cases, in subluxated and congenital cases. Yeah, you can do it in all cases of cataracts. Could be combined, yeah, with trabeculectomy, yeah. And I will show in the coming webinar with one of the famous glaucoma surgeon, small incision cataract surgery with trabeculectomy. And it will come soon. You can use premium lens. There is no contraindication to put the premium lens, the multifocal, trifocal lenses after small incision. You have a good rixus, you have a good bag, and there is no obstacles. There is no contraindication to put the premium lens. I think after mastering, it takes no time, average 6 minutes. And thank you very much. And this is a photo which was taken on the day of launching the Egypt chapter of this great society here in Egypt with my Indian colleagues, my Indian ambassadors from India who came to Egypt to launch this society branch, and also with my professors and colleagues. Thank you very much, and I hope this video is beneficial for all of you. Assalamu alaikum wa rahmatullah.